Okay, we're going to go ahead and get started, everyone. My name is Wesley Upland. I'm the Policy Director at Health and Medicine Policy Research Group. I'm really excited to introduce today's forum focused on the workers to support us all as we age. I have a few housekeeping notes. This forum is being recorded and will be available afterward on Health and Medicine's YouTube channel within the next week. We'll send out a link. We'll send out a link via email to all registrants of this forum. Please place any questions in the Q&A section, not in the chat. We'll be managing those and channeling them to the moderator and to our panelists today. We'll get to as many of them as we can during the last portion of the forum. A few more housekeeping notes. So we do have closed captioning enabled for the forum. You can turn this on by clicking on the CC at the bottom of your Zoom window and selecting either live captioning or the view full transcript option. If you would like to copy the transcript for your own later use, we will plan to close out the forum. Sorry, I have the time wrong on that. We'll be closing it out at 3:30, so feel free to download it before we close out the event. All right, so we're going to take a minute just to see who's in the room, who's attending this virtual forum. Please say hello in the chat and share your name, gender pronouns, title, and organization. We'll take a minute for that. I'm seeing those come in. Thanks. Please keep sharing. A little bit about Health and Medicine Policy Research Group. So our mission is to promote the health of all Illinoisans by advancing health equity. You can follow us on social media, Facebook, Twitter, LinkedIn, and Instagram. And we hope you will continue to connect with us because you registered for today's event. You'll continue to get invitations from us. And we are glad you're here today and hope you join us again at future events. One of those events is the Lead the Change 2022 Awards Gala. So this is our annual gala. It will be on September 29th, 2022 at the Ignite Glass Studios. We'll also have a virtual option for that, and we hope you will register for that. We also are, we're really glad to have sponsors of that. And so if you're able to do that, please get in touch with us, and we really appreciate that support. So this is part 2 of a forum series. Today's forum focuses primarily on home and community-based services. And again, it's part 2 of a series focused on this question: where are the workers to support us as we age? To view a recording of part 1, focused on nursing home reform and workforce issues, you can go to our YouTube channel. You can also go to Health and Medicine's website. And again, a link will be sent to you following this event. We'll send out a link to both forum recordings. So now I'm really excited to introduce today's speakers and our moderator. So Paula Basta is the Director of the Illinois Department on Aging and is joining us. Teresa Collins, the Executive Director at Senior Services Plus. She's also the President of the Illinois Association of Community Care Program Home Care Aid Providers. Stephen McCall from the Data and Policy Analyst at PHI National. And our moderator is Robyn Golden, Associate Vice President, Social Work and Community Health at Rush University. She's also a board member at Health and Medicine Policy Research Group. So I'm going to turn it over to Robyn.
Thank you, Wesley. Thank you, everybody, for joining. Good afternoon on this more pleasant day today in Chicago. So no 100 degrees. We're glad about that. So we're so glad to see our panelists here. I hope you will all be showing your faces at some point, Director. So that would be wonderful. Oh, there she is. Okay, all right. So we can't say enough about how critical this issue is when you think about the numbers of what we're talking about in terms of older adults and needing care, the fewer numbers of family caregivers, all of the combined is just kind of such a critical time to be talking about care in general, long-term care, But today we're going to specialize and focus on home and community-based care, which often is missed. So I salute our planners in making sure it was covered through these series. So I want to kick us off by just having the group kind of talk about the panelists, talking about their main issues when it comes to their thinking about the direct care workforce. And I'm wondering if you would start, our director, Paula Basta, and what do you think the department is doing to ensure an adequate supply of home care aides and other direct care staff to meet the needs of the growing older adult population in Illinois?
Okay, great. Thanks. Hi, Robin. Hi, everybody. Glad to be on the call today. You know, the Illinois Department on Aging is keenly aware of the workforce recruitment and the retention struggles. Not going to lie, it's a perfect storm. And so the community care program, which is our largest program that we administer, our in-home service program, is a significant component of that. It's an area we anticipate also substantial growth for the need of services. So as more older adults are choosing to stay in their homes, and with the number of adults age 60 and older in the US expected to increase by 30% by 2050, home care aides are predicted to be one of the fastest growing professions nationwide in the next decade. That said, the work is challenging, and you know that we all know that we're losing in-home workers to less labor-intensive jobs that actually pay better. So the department has taken a number of initiatives to ensure strong support of our aging network workforce, including our in-home providers. Over the past several years, the department has provided numerous rate increases for in-home workers. By January of 2023, in-home rate increases and rates will have increased over 40% since June of 2019, which is when I was actually appointed, which was March of 2019. So again, we have already increased over 40% since June of 2019. In addition to those rate increases, the department is utilizing the federal enhancement with the FMAP. FMAP stands for the Federal Medical Assistance Percentage. So of 6.2% is to provide in-home providers with bonus payments. The department's also provided and has gotten, we were one of the first to get the PPE out the door. We also are giving offset payments for PPE to the aging network. And so we assist with the costs associated with getting those supplies and the masks and hoping and ensuring that our workforce is staying safe, and as they deal with still the effects of the global pandemic. It's not gone. So we need to be vigilant about that. Making sure people stay healthy and safe is very much one of our utmost important things that we want to consider. But in addition, though, to the rate increases, the bonus payments, the PPE, the department has provided additional flexibilities through to our aging network under the federal Appendix K. I'm not going to get too much into the weeds, but just know that while during the global pandemic, we were able to open up our waiver to get an appendix called Appendix K, and that federal CMS will then allow us and allows states, other states that have used it too, they are utilizing Appendix K amendments to address emergency preparedness, emergency response, and of course, we have, to deal with the COVID-19 pandemic. So included in the our department, IDOA's waiver in Appendix K, we have our applications been approved, and we have now the ability to allow spouses, legal guardians, preferred workers to serve as paid family caregivers to address the shortage of in-home workers. I guess, I also want to say that the department also wants to ensure additional safeguards. We want to make sure that that we're including running APS. APS has been out in the field since July of 2020. So we want to make sure that we're looking at having eyes on people that are most vulnerable, because so many people were not being able to get out and about. And so we really take that APS population very seriously. So we wanted to make sure our providers are getting out, case managers are getting out and seeing those folks who are calling it APS referrals. So, I want to make sure you see that there's lots going on, but there's lots to do. And I want to make sure too that we know under, again, Appendix K, we temporarily waived some of the pre-service and some of the in-service requirements for in-home workers to ensure that there would be adequate workforce. And then we basically we're following the statewide Illinois Restore Plan. Illinois Restore Plan is, we're still in phase 5. We're still hopeful that we're going to get through the pandemic, so we're making sure that our sister agencies like IDPH and all of the rest of our sister agencies are following the state plan. We want to make sure if your senior centers are starting to open up. Personally, I myself have been out and about visiting once again throughout the state, some of our centers, that people are coming, and they're coming, but in a safe manner. So as you know, who was affected most by the pandemic, it was older adults. So I just want to make sure that people know that, we're working on it. It's a struggle, but together, it's the only way that we're going to get through it. So thanks. Hope that was helpful. Thanks, Robyn.
Director, that was incredibly helpful because I'm not surprised, but I'm impressed of the many angles you're taking, the department's taking with your leadership to get to this. So thank you. Teresa, do you want to speak to the issues at hand a little?
Absolutely. Thank you, Robyn. Thanks for the opportunity to be here. This is definitely really at a crisis level. The question, where are the workers to support us as we age? I wish I had the answer. I wish someone had an answer. We have best practices and we have suggestions. We have things in place, but we've still, as the director mentioned, we have a lot of work to do. I've been with Senior Services Plus. It's a small 50-year-old not-for-profit in Southern Illinois for going on 15 years. And in my time at the organization, this is the most challenging time we have ever faced for recruitment and retention, not just of home care aides, but of all positions, of course. And I know we're not alone, and we're not alone in our industry. Other industries are facing this as well. But in my role as the president at the Illinois Association of Community Care Home Care Providers, our statewide association that represents, the 100,000 plus seniors in the state of Illinois who are receiving services, in-home services, and over 50,000 caregivers, home care aides who are providing that service. Whether it's a not-for-profit organization in Southern Illinois, a statewide large for-profit agency, or a national chain, we're all experiencing this. And as Director Basta mentioned, we all know this is one of the fastest growing jobs in the US. But this disaster that we are in has been decades in the making. Now, I wasn't around 30 years ago, but I was around 15 in the industry. And I remember my very first meeting of the statewide association. I remember going to the meeting and coming from a different sector of work, hearing people around the table talk about the boomers and talk about this aging population and talking about what we were going to do, that we had to act now to be prepared for what was coming in 10 years and 15 years and 20 years. And we did a lot of discussion, a lot of meetings. And now, here we sit 15 years later, still talking about this issue. And, I think there were steps made, but there is still a lot of work to do. And it is going to take, as Director mentioned, a huge team effort. I'm so thankful to her staff, and the administration and the governor's office for the work that's been done thus far, and for the open door policy that she and her team have for talking with us and other providers within the network. But I'm hopeful that today, through this discussion, we are going to motivate people to not just continue to discuss, but really start to take some very strategic steps to move forward in trying to deal with this workforce issue that we're facing. It's not just about, at this point, recruitment. It's also about how we retain the current workforce that we do have, the limited number of home care aides who are doing this work. I think there's a multitude of reasons why we're facing this challenge. COVID and the current climate of our country has not helped at all, but we have to attack it head on and continue to make strides, because there, again, is a growing number of people in our communities, in every one of the communities across the state of Illinois, who are in need, who helped build the communities that they are living in, who, like you and I, want to continue to live in their homes where they're comfortable for as long as possible, as long as it's safe, and with a minimal amount of assistance, which we know saves the state money and creates a greater quality of life for that individual. Like services, like the community care program, Meals on Wheels program, other home and community-based services, that can be a reality. But the workers, the workforce has to be there.
Right on. Thank you, Teresa. So well said. Steve, may we call upon you to get your perspective from the national level and the policy perspective? We'd love to hear.
Yeah, of course. So just by way of background, for those of you who aren't familiar with our organization, PHI is a nonprofit research and consulting firm that aims to improve the quality of LTSS by improving and strengthening the direct care workforce. And we've been doing this work for 3 decades. So, I think similar to previous comments, this has been a long time coming, the crisis that we're currently in. But I also feel like even though we're sort of at this inflection point in terms of our challenges, there are also unprecedented opportunities to really take action and transform this workforce to improve services both now and in the future. Just to put some numbers to what we've already been saying, the direct care workforce across all LTSS settings is now the largest workforce in the country with 4.6 million workers. And in the next decade, from 2019 to 2029, the most recent projections we have available, this workforce is projected to add another 1 million jobs, 1.3 million for the whole direct care workforce and over 1 million for the home care workforce in particular. So we're seeing this exploding population of older adults in need of care really driving up demand for this workforce and for the home care workforce in particular, thanks in part to federal and state action to make those services more available, but also shifting consumer preferences toward home and community-based settings over residential care. But despite that high demand, the workforce is still earning a poverty wage, right? In 2020, these workers were earning $13.56. That's the median wage that they were earning. And 10 years before that, after adjusting for inflation, they were earning $12.53, right? So we've made some incremental progress. The purchasing power of these workers' wages have ticked up. But what we know now in the kind of post-COVID recession economy is that so many other industries are increasing their wages to attract job seekers back into the labor force and back into the workforce. And we know that employers are really struggling to keep up in the LTSS space because they're so reliant on Medicaid funding and other sources of public funding like Medicare. So where do we go from here, right? I mean, I think first and foremost, we absolutely need to address the compensation issue and lift these workers out of poverty, make these jobs providing a family sustaining wage, et cetera. But wages are only part of the picture, right? We also need to attend to the various other job quality concerns that have long characterized these jobs, including an inadequate level of training and professionalism, opportunities for advancement. These jobs are typically dead-end jobs. So for a worker who's scanning the job market to see where they might seek employment, they might be looking at those jobs that have management tracks and other rungs on the ladder more favorably than the jobs in the LTSS space. So it's not just a matter of elevating the role of these workers to improve health outcomes for consumers, but also ensuring that workers who are entering the field can really see a future and a career in this space. And then there are a number of other areas that we can work on, right? Supervision for these workers, ensuring that they feel well supported in their really challenging roles, which can be especially an issue in the home care space, where these workers are often working independently in the field and may not know who to call when there's an emergency. Or if they do know who to call, they may not be able to get in touch with that person. So making sure that they have a really strong supportive environment, even though they're out in the field, I think is absolutely essential as well. What makes all of this attainable and this moment in particular so exciting is we've had this, as we've already talked about, this massive influx in federal funding at the state level, with the potential of additional federal funding on the way. Illinois does have that ARPA spending plan to sort of allocate those funds with things like retention bonuses and other initiatives. But I think that absolutely we need to be thinking creatively about how to invest those funds in the immediate term to have that lasting impact and ensure that services are adequate for consumers and these jobs are good enough quality that people want to stay.
Thank you, Steve. I think one of the hardest things, and what I've learned as, just working in agencies and hospitals over the years, is we don't always get the direct connect as leaders, managers, between you treat your staff well, your employees well, then you're going to have higher quality of service. And it's such a simplistic concept, but so often is not embraced. So thank you for reinforcing that. I have a question. I'm going to pepper the questions from the chat with some questions that I have, and I'm also would love some interaction between the experts on the panel. But Director, I have a question for you. Wonder if you're able to. Thank you. How does IDOA determine what rates support a wage level sufficient to recruit home care workers? How would you describe such a wage given the competition for workers right now?
Yeah, so basically what I know that they've done in the past at IDOA is do rate studies. So basically they're having companies come in and do a long-term study of what the rate and the rate increases are going to be. So that's how they've determined it in the past.
Sometimes those determinations are a little behind too, and particularly accounting for inflation. I know that we throw around $16 an hour, I hear, but I still don't know if that's livable. Steve, anything national on that question about what's?
Yeah, how much is enough? I mean, I think that there are a few ways we can think about this. First is wage competitiveness, right? We have the data from the Bureau of Labor Statistics to be able to assess how home care worker wages and other direct care worker wages stack up against other occupations with similar or lower entry-level requirements. And what we see nationally is largely these wages are hovering around those occupations with lower entry-level requirements, right? So it takes less to enter those occupations. And as we've talked about, I mean, those occupations may also have less emotional strain, less physical strain, right? They might have those additional opportunities for advancement. But then I think that we can also think about, a living wage. So what is a living wage? It's what the compensation required to ensure a worker can afford basic goods and services, right, to support their families. And this is a bit of a moving target because for workers, they may have a spouse who's earning, they may be a single adult with no children, or they may have a large family. And the living wage varies according to those various household characteristics. So I think in that regard, we just need to do the best that we can to, again, lift workers out of poverty, ensure that they can, move off of public benefits. I mean, about half of these workers are enrolled in some form of public benefits, but without experiencing steep cliffs, right? Because there's this other challenge there too of, if a worker increases their wages just a little bit, they might lose their health insurance. And we absolutely don't want that. So Another element to this compensation equation that we should be thinking about is, first of all, what is that target wage of that a worker can sustain their family on, but also how do we make sure that they're not experiencing pitfalls along the way? So I think those are just a few ideas of how we get there. But in order to enact that through policy, I think that absolutely establishing wage floors, so ensuring some accountability for Medicaid funds that are flowing out the door to employers can help ensure that there's sort of a level playing field among employers. These funds are being used appropriately and invested in the workforce. And those wage floors could be indexed to these various metrics we've talked about, either a competitive wage. Some states, as of recent, have explored indexing wage floors to the minimum wage. So as the minimum wage continues to rise, so does wages for workers themselves. So there are policy levers that we can pull to ensure that workers are making those higher wages along the way.
Robyn, if I could just
Yeah,
add
no, I
in
was
there.
just going to turn to you. So great.
Well, I just want to piggyback, I really think it's important that we think about the statements Eva made about individuals, this is definitely more than just wages. But these individuals, brings up such a valid point, real life case scenarios where individuals are making a minimal salary rate anyway. And, just to elaborate a little bit on Director Bass's comments on the Department on Aging's rate and how that is determined. These salary or rate studies that have been done often lead to rate increases, of course, which is wonderful. And as a licensed provider through the state of Illinois in the community care program, all of the providers have to show each year, do a direct service cost report that shows that there's a 77-23 split, that at least 77% of that rate, that reimbursement rate that providers are receiving, goes directly to the caregiver, which is wonderful. But often we see these minimal increases happen each year, and we go back to our staff with, hey, great news. We're so excited to let you know that you're going to be going up to $15 per hour. And many of the caregivers that we employ and that nationwide are employed are often female, they're often single, and they're often parents, mothers. And as Stephen mentioned, they're receiving benefits, whether that be medical benefits through Medicaid or other types of benefits that are allowed through the state. And they'll say, that's great, but that minimal increase is just going to push me 30 cents, $3, $10 a month over that minimum threshold, and I'm going to lose my $200 a month in EBT benefits that I need to feed my children. And so the salary piece is one part of it. But I think the other thing we have to think about, at our agency and at many others statewide, these jobs, while there are plenty of hours out there for caregivers to work, many of them are working multiple jobs. This is a second, third job for them, and or because of other responsibilities at home or with caring for a parent or a loved one at home, they're not able to work full time. And so because these are part-time positions, often the other benefits that are afforded with full-time employment, they're not receiving. So things like paid holidays, paid medical leave, all of these other benefits that really mean a lot. I think that one of the things that is a benefit or a plus in the work here is that, and we try to really inform our staff of this and use this as a recruiting tool, is about the job security. There is job security here. If you are looking for job security, this is not a career or a job that's going away. There is an unlimited amount of work available, and it's also a mobile job. This is a job where you can leave from one organization to another, from state to state, nationwide, worldwide. There are caregiver positions. So trying to really focus on those as well when pay is not necessarily something you can tout as a recruitment tool, or things that we, I think, as providers have to lean on.
Great point, thank you. Stephen, there was a question that, do the 4.6 million home care folks you cited, are they all with agencies, government, or is that the quote unquote gray market as well, would you say?
Yeah, that's a great question. So to clarify, in some cases, depending on the design of Medicaid programs, consumer-directed workers may be included in those numbers. So under those Medicaid funded programs, where there may be sort of joint employment implications, or just where states have made the extra effort to capture those workers, they would be included. But for folks who are providing assistance to people in their private homes, potentially off the books, they're not included. And we have worked really hard to figure out, who are those folks? What is their job quality like? And frankly, we have no idea. Many of those workers may be undocumented and may not even want to respond to the US Census, right? So when it comes to capturing additional data on that segment of the workforce, it's basically entirely unknown.
What, do you have a sense that we lose people to the gray market, or that ability to get cash and maybe a higher rate? And how do you message to that workforce? Or, I mean, that is a potential workforce out there. So many people are not part of our systems.
To some degree, I think there is a wage competitiveness challenge there, right? Because without the sort of administrative overhead of, running an agency, a worker may be able to charge a lower rate than their current employer and make a higher wage. But I think there are mitigating factors there too. I mean, for many workers, the agencies are providing an employment experience that they might prefer to being an independent contractor or sole proprietorship, like the supervision and support, scheduling support, connections to clients, right? So I think that, it's sort of hard to say, how many workers we're losing to that space. I think by and large, the greater challenge is that we're losing workers to Amazon distribution centers, fast food, retail. These are spaces where employment experiences where they may be getting the same level of support, but earn a higher wage, and may even have, I'm glad that we talked about that Teresa mentioned the scheduling issue, because there's actually a whole field of academic research just devoted to the home care scheduling challenge, because there are so many intricacies of scheduling a worker, and including things like drive time, availability of clients, availability of workers. And we've talked about wages for workers and shortages there, but there are also pockets of shortages across organizations, right? So when we talk about supervision and scheduling, those workers too may have very limited capacity to sort of spend time on figuring out the scheduling conundrum, especially when there are hundreds of workers or even 50 workers, right? And these broad pools of clients who may be distributed all over a city and in rural areas all over the county. So I think that in that regard, there are other private sector strategies that we've seen emerge, particularly in response to criticism of last minute scheduling. Places like Amazon, Walmart, Starbucks have developed scheduling tools that empower workers to first have a set schedule that remains consistent, but then also swap shifts or accept new shifts as they become available. So sort of putting that scheduling responsibility or making the scheduling choices available to workers can be one way that we can better optimize the workforce, notwithstanding all of the challenges related to their own family caregiving responsibilities, their own experiences in public benefits programs. I still think that these kinds of tools could really have value in optimizing and better distributing the workforce.
Any states that are doing it better than others that we should be looking at in our work at Health and Medicine?
I think that Not yet, right? So one intervention that states have adopted, like something that a state can invest in to sort of provide a similar experience as these apps at Starbucks and Walmart, is called a matching service registry. They're largely used in the consumer directed space to help consumer directed workers get in touch with consumers who are directing their own services. But as of recent, Advancing States, a membership association for Asian and disability state agencies, is has already launched a job board called Connect to Care Jobs. And I think as part of their reworking of that platform, they're considering ways in which they can provide this technology to, say, an individual worker, an individual consumer, to sort of reap some of these benefits that technology can provide in that space.
Thank you. Any other best practices from Illinois that you can think of, Teresa? I mean, do those fit, as Stephen is talking about some of those?
No, they absolutely do. I think other things to think about, and it's not something that employers like to talk about, and it's not glamorous, and it's not often a real benefit to the home care. But I think one thing we do have to think about is when we're utilizing workers from an agency, there are protections on both sides for both the client and the caregiver themselves. Things like that the staff, for the client, that the staff are licensed and bonded and insured when they're coming from an agency, and that when your caregiver is going to be out of town or on vacation or calls in sick, there is an opportunity for a sub caregiver. And so that individual who might need a meal prepared or a medication reminder isn't going to go without that. But there are also protections in working for an agency for the caregiver themselves, things like having workers' compensation benefits. I mean, that's not a popular thing for employers to talk about, but things happen. Particularly, things happen in homes. And when we're out doing essential work for activities of daily living, like running errands, car accidents happen, falls, slips, and trips in the home happen, not just to the client, but to the caregiver. And so having those protections from an agency are also important. But I do agree with Stephen. I think, really one of the things, again, at our agency that we're trying to focus on as we move forward and navigate this is really at looking at creating autonomy, looking at flexibility, looking at work-life balance, looking really, at that caregiver and putting into place whatever we can that makes this experience one that makes them want to stay. I think it's very important. Stephen mentioned in his comments that these are not individuals who are going from agency to agency anymore, like we saw 5 or 10 years ago. His point is well taken. We are seeing individuals leave for retail and hospitality type work, where frankly, the setting that they're going into is known. You may not want to work in fast food, but every day that you're going into the backside of this restaurant and what your work environment is going to look like for the most part.
Yeah.
But when we're talking about going into individuals' homes, that's a lot of unknown. Not just that individual often is in the home, but there are family members and friends often in the home. The settings may not be conducive to what you or how we may live, and we still have to be respectful and understand and take a person-centered approach that this is their home. And so, I think any of those things that we can put in, flexibility and scheduling, utilizing the great technology that is available and out there, is definitely going to be key moving forward.
Yeah, that home piece is also, it's more isolating than being in a facility. Think about that, just in terms of how do you so much of our work lives have to do with meaningful connections, and not that they wouldn't be having meaningful connections with the people they're caring for, but it is definitely, they don't see their cadre just right next to them in another room.
That's a good point. That's a
Yeah.
good point, Robyn. And often, because this is such physically and mentally demanding work, when I might be able to go to the office next door and vent to a coworker, they're not able to do that.
Exactly.
And so that's why that caregiver and office, whoever's on the backside in the office, that's why that relationship is also very critical.
Yeah, I wonder if there are certain people that prefer facilities and certain people prefer community for that reason. And it's something to look at maybe differentially as we message in terms of recruitment. The director also mentioned the CNA apprenticeship program, which she put in the chat, which looks pretty very important too. I don't know if you wanted to say anything else about that, director, or we should just.
Just that IDPH just came out with that, so I thought people would be interested to hear
Yeah.
about it. It's the latest thing that we just received through them. It might be something that this group might want to have someone from IDPH come and speak to.
Absolutely, thank you. So here's a little bit of an interesting question. Someone from a memory care assisted living, they're doing well with CNA recruitment, but their issue is more with LPN staff. Is there any talk of Illinois allowing med techs to distribute meds? Or maybe that's being done nationally, Stephen, that you might know of. This person feels it would help a lot. These are things that I've heard in the past. And any thoughts about that, opinions? Anybody else know where we're going or where that might be going in our state?
I can just add that, I think that overall, from a national perspective, we have a scope of practice problem, right? I think that there's a general distrust in workers' ability to do sort of like basic care tasks that we might be able to do ourselves, for our own personal medical care. Things like eye drops, right? I think that absolutely we should be thinking about scope of practice and what can be delegated to workers. Medication administration, I think, is a big one. Of course, with adequate training, adequate supervision and oversight, I think that there is sort of a valid concern among folks like registered nurses that the more that we delegate these tasks, the more at risk they are in their own careers. So I think that we have to be cautious about the way we introduce changes in scope of practice, but that also is an opportunity to structure opportunities for advancement for workers who are experienced in the field, can demonstrate competency in some of these tasks that they're not currently able to do, but could possibly do. If we can pay a direct care worker a higher wage to perform those tasks, but maybe a wage that's a little bit less than an LPN or RN, that's cost savings generated. That's an opportunity for advancement for the worker and a better experience for the consumer. So absolutely, I think it ought to be on the table.
Yeah. Grace, the director, do you know if anything's going on in Illinois in relation to that?
I know in the provider network, this is something that gets brought up a lot. There is a lot of need around medication dispensing, but in the community care program, we are also utilizing automated medication dispensers and currently doing medication reminders. And I think, as Stephen points out, we have to remember that, with the right training, with hands-on experience and oversight, things are possible, but I agree we have to watch the direction we go in, and maybe there's room for opportunity. As we talked about, the director mentioned the CNA pilot. I think it's wonderful, and I think creating this career advancement, this career ladder and path is it has to happen. But I think there are some steps that we have to be cautious about because of liability and other things, before we move in that direction.
Great, thank you. I think there's also just a message in the chat. Are we starting with high school? Are we starting earlier with people to try to cultivate that? And I know Health and Medicine, very much an AHAC program and trying to get people interested in health careers earlier. And just wondering if there's any thoughts about that or any best practices that anybody's aware of.
Yeah, there is a group that we meet with, but it's a bunch of stakeholders that have been talking to how we can get in high schools, the track at the community colleges, but there's other issues with educational associations and things. So we're working on that, but I don't know anything else, maybe Stephen or Teresa.
I think that, there are several examples of states that have launched high school-based training programs for direct care workers, either to become CNAs or home care workers. And absolutely, I think if you can sort of present these jobs as, for example, a stepping stone into a career in healthcare, then there may be those kinds of knockdown effects too, knockdown benefits of workers then going on to college and getting a nursing degree and helping to address that shortage. But I think there are also a few things that we need to keep in mind as we think about those kinds of interventions. And first is the person-centered experience. You know, for some older adults or people with disabilities, they may not want a high schooler to be providing their services, right? So ensuring there's a good fit there for a much younger worker with an older adult or person with disabilities, I think is really important. And then for another issue we need to think about for those younger workers is this may be their first job, you know, out of high school, maybe their first full-time job if they're sort of pursuing this as a career. And they may need some extra support and some extra, you know, we've talked a little bit about, Teresa mentioned, you know, and we talked about the isolation that often characterizes these jobs, but it doesn't necessarily have to be the case, right? I mean, there are organic ways in which workers form connections with each other. You know, I heard from one worker during the pandemic at an in-service training, they started a group text with a few of their classmates and then used that group text to navigate the public health crisis, right, together. But this is also an opportunity to think about peer mentorship, right? Peer mentorship can be an opportunity for advancement for a more experienced worker who can then mentor these younger workers and sort of be on the end of the line. You know, I love the example that Teresa gave of going next door to be able to vent to a colleague about something that's happening at work. Peer mentorship can provide that kind of low stakes opportunity to just relax a little bit and sort of be able to articulate what you're experiencing in the workplace without, you know, being afraid of any sort of disciplinary action or, you know, looking bad in front of your supervisor. So for those reasons, I think that, you know, if we're going to bring younger folks into the workforce, you know, that there may be a great opportunity too to pair that on the other end with new peer mentorship programs.
That's great.
I agree. I just want to, you know, piggyback kind of on what Stephen said. I think that that's also an opportunity for kind of building in a tiered structure for even for your caregivers and creating, you know, whether it's called a senior home care aide or level 2, whatever you want to call that, but that can come with some additional either salary or other benefits, and that can be something again that is enticing to achieve, you know, and there's great pride in our caregivers when they do those things. But I think we also need to look at the other end of the spectrum. People are living longer, people are working longer. And I think to Stephen's point, there is a lot of peer-to-peer, there is a lot of connection we see in our more seasoned, for lack of better words, or older home care aide with the client. And sometimes, you know, we have caregivers who in age are more senior than the individual they're caring for. They meet all the requirements, they pass all the physical backgrounds, all of these things, but they need and want to work. And this is really, really rewarding work where you're going in, there's so many things in common and things they can talk to, and they're just providing that little bit of assistance. And how rewarding to go home and share with your family that at 70, you're working with this individual and helping them stay at home. You know, I think we also have to explore that there are senior employment programs across the state of Illinois, and that's something we also need to tap into.
Yeah,
Absolutely.
Teresa,
Yeah.
I just wanted to add, Teresa, you know, I'm so glad you bring up this point, because actually the fastest growing segment of the labor force is not the younger end, it's 55 plus, right? So this term retirement age has lost all meaning in the modern era, right? And people are living longer, they're healthier for longer. And while absolutely everyone should have the ability to retire someday, some people who are retiring, right, and may have limits on their income, might want what's called an encore career. So after their office career or whatever they were doing, blue collar job before, they want to give back to the community and earn a little bit of a part-time wage to supplement the Social Security. What a perfect opportunity, right? I mean, I think that camaraderie too, you know, especially for, you know, 55 plus folks who are assisting 65 plus and 85 plus people. I think there's a real opportunity there to provide a really quality service too.
So an interesting question about worker protection. So there was a question about what worker protections are needed for home care workers. For example, Chicago is now requiring written contracts for such workers. But then along those lines, there's another question about how do we protect workers from being accused of elder abuse at times or neglect? And I think those kind of go hand in hand. Any thoughts about that from the three of you?
I'm glad that this question came up because I was thinking about this as Teresa was talking about the benefits of an agency employment structure. Now, of course, some workers may really opt for a sole proprietorship, or they want to be kind of like a small business owner themselves, be their own boss. That's great. I mean, I think I'm not problematizing that model. But what I did want to mention is there is this trend in the field that's very difficult to measure, but we hear reports from the field that some kind of unscrupulous employers might be setting their workers' wages, setting their schedules, effectively acting like an employer, but then classifying workers as independent contractors that they don't pay employment tax, unemployment insurance, the various other forms of insurance that Teresa mentioned. And I've heard from employers across the country that some of these agencies will poach their workers, offering a higher wage, but come tax season, workers are hit with this enormous bill that they didn't see coming. So I think that in terms of protections for workers, making sure that we have a sense of how many workers are classified as independent contractors and whether they're actually independent contractors, I think that that's really important. Just issuing guidance for employers who may just see this as a promising opportunity to increase wages without knowing the kind of legal implications they may be embarking in and the wage theft that they may be committing. So I think that's really important. But then also establishing enforcement agencies, right? New entities that workers can go to when they're experiencing wage theft, where they can feel safe doing that, I think is really important. So one example is in New York City. They've developed what's called a division of paid care, where this is a special entity devoted solely to enforcing labor protections for not just home care workers, but also nannies and cleaners and other forms of domestic workers. Because especially for people who may be undocumented and sort of have the looming threat of deportation hanging over their head, making sure that there's an entity with specialization in serving that population, I think is really important. And then finally, as well as guidance, working directly with workers, real enforcement power, like enforcement actions against the bad players who are taking an unfair advantage over agencies like Teresa's and others. I think a lot of times we hear from workers that when they're experiencing real wage theft and they're scared for their jobs, et cetera, and they call labor enforcement agencies, they don't hear back for 2 or 3 years when they've already left that employer because they've just, the issues were just totally unresolved and they were sort of fearing for, again, deportation, other forms of labor abuses. So this is a particularly vulnerable workforce to these kinds of things. And absolutely, we need to make sure that the labor protections that are already on the books are being enforced well.
Thank you. Teresa, anything about that? And or do you want to touch on immigration a little in terms of what your organization, how you view immigration issues?
Sure. Well, 2 points I just want to mention, we talked a little bit about the how things affect this population and what protections we can put in place for our home care aides. How do we protect them from false accusations? I want to say, unfortunately, we can't always protect them. Individuals, particularly this population, there can be confusion, there can be dementia issues. We all know that, and there can be accusations made. But what I can say, as an employer who we've seen this happen, I've seen it happen personally over the years, many times false accusations made from, she took a soda from my refrigerator to a piece of jewelry, all kinds of things. We always tell tell the client or the client's family, file a police report. Let's get this documented. And we launch a full investigation, but we don't take any punitive action against the employee. And we make it very clear to the employee, that this is going to be thoroughly vetted. We understand, we hear your side, and that, we're not going to make any assumptions. We're not going to make any rash decisions as an employer, because while things can happen in the home, and they do happen in the home, there are vulnerabilities there. There can also be false accusations. And so I don't know that we can protect from that, but I think as an employer, we just have to understand that in this work, that's going to come.
Yeah, and who the person is. The number of times as a social worker working in home care that I ended up finding the wallet stored, hidden where the client hid it.
Most of the time.
To remember where it was in some of the most creative places. So.
Yes, the majority of the time. So that does happen. And then in regards to immigration, I think one of the things that's really great about the state of Illinois is the diversity. We have many individuals in the state who are non-English speaking, or English is not their primary language. We have a multitude of providers that in our statewide association across the state who specialize in ethnic populations, and the caregivers in their industry or in their organization are very fluent in those languages or from that population. That is very difficult because as we're seeing this influx of aging immigrants and immigration trending down, or there being policies put in place nationally that limit immigration, we're going to face an even greater crisis here, because that population, as we've seen as an organization, even in Southern Illinois, that's a difficult, it's difficult to get into those close-knit, often fearful groups. And to break into that, obviously, we all want someone that we feel comfortable with, that understands us, that is, aware of our wants and our needs and our preferences based on all of those things, religion, ethnicity, all of that. And so I think we're going to see an even greater challenge in caregiving as we move forward nationally. And I'm sure Stephen can speak to that much better than I can.
Yeah, I'll just add, I think, over the past decade, kind of before the shifts in the policy landscape that you talked about, Teresa, we've seen that immigrants as a proportion of the direct care workforce have grown a lot. Right now, it's about 1 in 4 workers nationally who are immigrants. And we've also seen, just to your point, that while the older adult population is the fastest growing segment of the population, the older adult immigrant or Hispanic or Latino immigrant population is growing even faster, right? So I think that I just wanted to signal boost that point that you made, Teresa, about the importance of a person-centered experience can often depend on having a worker who speaks the language and is part of the culture, and sort of all of that is really important. So what do we do about that? I think first and foremost is to not put in place those kinds of xenophobic immigration policies, right?
Yeah.
I think that this is a time when we need more immigrants, not less. And they're, as you said, they're part of the rich fabric of our communities, and these jobs can be, a real employment opportunity for immigrants who may face barriers due to education, et cetera, in other sectors. So I think that there's just this clear need to bring immigrants into this workforce, and we shouldn't be making them afraid to leave their homes. Yeah. We should be welcoming them both into the workplace and our communities. I think, it's really essential for the system.
Or forever not being, considered citizens after they've invested in this kind of work for as long as many of them have. It's unbelievable. Interesting question from the chat. Have we seen any application of the gig economy model to home care, such as TaskRabbit or DoorDash, etc.? Any thoughts about that?
Robyn, I'm frankly a little dubious, right? I think that, I think that again, for
Trust me, it
folks
wasn't
who,
my question. I wouldn't have even been thinking that way. I can barely do it myself, so.
well, I want to emphasize that a matching service registry that I talked about is effectively that,
That's
right? It's a
true, you're
way
right.
for folks to establish an employment relationship, and perhaps there is a role for technology to help fill in the gaps, right? Like when a worker can't show up for a shift, maybe technology can have a role to like quickly connect someone with a worker who can fill in that gap and make sure that they can get out of bed, et cetera. But the piece I'm dubious about is that like that model as an employment model, right? I think that all of the challenges that we talked about related to independent contractors, I think there's a heightened risk there, right? Where, as we've seen in court cases, companies like Uber are sort of really pushing the limits of the independent contractor model versus a full employment model, a W-2 model. So again, I think that while definitely technology can have a role in connecting workers and consumers, and even for agency employed workers, these can be an opportunity to build worker schedules and build business for the agency, right? I think that's the positive. The negative is the potential for labor abuses and for inconsistent schedules and the kinds of challenges in that regard.
And if I could, Robyn, I would
Yeah,
also
no.
add, I think we have to look at everything as an option, but I think that where there could be issues there is, in that, as we mentioned, this is a workforce, particularly through the agency model, where there is a lot of oversight. There are a lot of requirements for agencies, at least here in Illinois. I can't speak to other states as far as, pop-up visits, pop-up supervisory visits, telephonic check-ins. We use the EVV, the electronic visit verification model here, where home care aides are clocking in and out, and there's a ping from their phone that they're using to ensure they're in the right area. And so I just think some of those oversights are so critical, and losing the with the agency model, these individuals are background and screened, and they have ongoing training that we assure is appropriate and is being done properly. I just think there are some challenges there if you go to that type of model. But I do worry, I'll be very frank, I've said this in our association for many, many years, I worry about the sustainability of this model. And that is terrifying when you've got a growing number of people in need who require these services to be able to stay in their community and pay taxes and purchase goods and keep our economy as robust as I guess it is. But, we need that. And so I do think we may need to explore some different models. We have a lot of senior living facilities or communities where it could be possible to look at more of a group setting. Mm-hmm. And so on, Tuesdays, this caregiver is going into this senior apartment and she's doing laundry for Mrs. Jones, but she's washing dishes for Mr. Smith and doing a variety of tasks for multiple clients. And maybe those individuals are able to gather in the community room at the apartment, and she prepares them a lunch, and they sit and they socialize, and they have some interaction with peers, and they get those household chores they need done. Or maybe she comes in and picks up 2 clients rather than singularly working. And that model is not going to fit for everyone, and it's not going to fit in every community. But I do think those are things that we have to consider moving forward to be able to sustain the amount of people and the amount of care that's going to be needed.
It's so much more fluid and creative, what you're talking about. I guess the other question that came out in the chat, which is interesting, is at what point, can we really have, it's still considered a waiver for people to stay in the community. It's not normative. And, for years it's been considered a waiver, at least in Illinois, Stephen. And how does the staying in the community how can that become the default, as opposed to people having to go into institutions when they reach a certain determination of need scale in Illinois or whatever? I mean, how will we ever be able to address that beyond people who have unlimited funds themselves who can do that? Any thoughts? And Director, this is a good one for you too. How do we deal with people with the highest needs who need and want to live in the community? Any thoughts, group?
It's a really tough one, right?
Yeah.
I mean, I think that I think my mind first goes toward the need for attention and reform in residential care as well. I mean, I think that, you know, in your oldest years, you know, do you really want to move into a nursing home that feels almost like a hospital where half of the residents have just been discharged from the hospital and are only there for 100 days? Like, it feels like you're living out, you know, the twilight of your life in a place that doesn't feel like home. But that doesn't have to be the default. Like, I think that part of, you know, maybe one way in which we can ensure an adequate level of support and services for people with the highest need is to make sure that nursing homes feel more like home and come with the autonomy of living at home and look like home, have pets like home. You know, I think all of these things are possible. And there are nursing home advocates who are really, you know, have made a lot of progress in advancing that model. But, you know, I think beyond that, I think, you know, one often neglected element of workforce development in home and community-based services is support for family caregivers, right? I mean, one way, like, of course, we need to fill vacancies and ensure an adequate level of support for people. But we also need to think about bending the curve on demand, right? You know, to Teresa's point, like, the demand that we're experiencing in the space does feel overwhelming. So ensuring that family caregivers have enough support so that they don't get completely burnt out, they have adequate respite services, they can hire help when they need to. That investment in the family caregiver on the front end can actually improve the system and the workforce on the back end, right? So
stave off the crisis, absolutely.
Yeah, exactly.
Director, anything you want to say to this?
Yeah, just a vast array of aging services should always be within everyone's reach. So that means everything. That means, and I know Kathy Rhodes put in the chat, ADSs. ADSs should be highlighted and continue.
So underutilized, absolutely.
And it's just one of those things that we have got to get better at getting them out and about it, but also getting more ADSs, getting folks that want to do the ADS model. I think that's part of how we need to also help folks stay within the community, especially as you get older, especially as you get more frail, and especially also for caregivers. So, but you also have the AAAs out there. You have the CCUs doing stuff, but the AAAs are out doing, you know, getting lots of dollars. They're getting ARPA funds right now. We're doing regional meetings with our providers, making sure people know what they're utilizing those dollars for. In our state budget, we just encouraged, and actually we're able to get another $4 million to the AAAs for caregiver supports and services. So there's there's lots of things that already exist, but need to have somehow or another people know more about them so that they can utilize those services when they need us and not wait till it's too late.
Great point.
And I think stacking those services, you know, combining different levels of service and support, and whether, you know, in-home service plans, while they're based on need, and sometimes now as providers, we're having to just provide the bare minimum. We're not always able to fulfill those plans at 100% because of the workforce shortage. So coupling those plans with, you know, the caregiver comes in the morning, feeds breakfast, gets the individual dressed, and gets them to transportation that takes them to an ADS. I think creating that really, again, that person-centered approach where things aren't cookie cutter. But I also think, I think the waiver is important. I know that no one wants to think that the norm is, or the diversion is a waiver, but but I think that the waiver is important, and I think that we continue, and I'm really happy with the department and the administration more recently that we've been able to have some flexibility. You know, Director talked about Appendix K. That has helped not just providers be able to hire on additional workers, especially especially during this COVID crisis. But long term, it's been better for the front end user, the participant in the program, to get their services. And I think reevaluating, because the needs of seniors now are not the same as they were when the 1915 C waiver was originally written.
Right, right.
The population's changing, the needs are changing, and so we have to be flexible. It's easy to look at the model and say, well, this works, and so we keep it. But I love the fact that the department's been open to looking at some flexible services, and has come to us as providers and stakeholders and said, what services do we need? What are you seeing? What are you hearing? If we do a little bit of home modification, if we have some extra money and we do a home modification and put a grab bar in, and that $35 grab bar allows someone to stay in their home for 3 more years. Wow. What an investment.
Director, you're breaking down the silos. Thank you. And the less rigidity, the better, and the more person-centered it will be. Let's talk about training for a minute. I'm struck that sometimes, when we have a geriatric workforce enhancement program at Rush, and when we approach home care agencies to provide some training education for their staff, there still are some places out there, and maybe I'm wrong, that really expect their staff to engage in part of training and not get paid for that. Has that still exist, Teresa? You're reacting, so maybe
I
talking to the
am
wrong
not
places, so
aware.
I'm glad to hear that.
I would not imagine that to go over very well at all.
No.
I believe, like you or I, those home care aides need and deserve to be compensated for their time. That is part of their job requirement. There are criteria that they must attend so many continuing education or in-service hours annually, which is wonderful. And it's great if agencies go above and beyond that minimum, but by all means, those individuals should be financially compensated for their time.
Absolutely. Thank you. I hope we were just talking to a few agencies that weren't doing it that way. I hope those were the exceptions and not the rule. Because you're right, when we're talking about people who aren't quite making a living wage, how do we expect, as many of them are going off to their second jobs, right, to take that time for training? So I have a little bit of a provocative question. I've been watching the community health worker movement, if you would say, and it really seems to be a movement. Everywhere I go, every meeting I go to, or on Zooms, different parts of healthcare and long-term care and services and supports are talking about community health workers. And I sit there and think, I've known direct care workers a lot longer than I've known community health workers in my career. And I think to myself, well, how is this very different? And how do we get the direct care workers to get the same adoration as community health workers are getting right now? Or do you think I'm off on that? Love to hear your perspectives.
I love this question, Robyn. I'll be provocative too. I think that, a lot of the reason why, I think that people generally hold community health in greater regard than the direct care workforce. And I don't mean to disparage that occupation. I think there's absolutely a role for a community health workforce system, right? I mean, I think that, the education that they can provide in their communities and sort of intervention to help improve health outcomes, all of that is great. But I think that the fact that we haven't thought about direct care workers in this way is inextricably linked to the people who do this work, right? I don't want to paint with too wide a brush here, but I do think that, because this is a workforce comprised largely of women, right? Who, historically this work has been part of the uncompensated domestic responsibilities of women, people of color, I think there's a direct lineage between home care work today and slavery of yesteryear, right? I mean, this job evolved out of human trafficking, right? And immigrant work. I mean, I think for all of these reasons, the work is devalued. And I think for, I don't want to accuse everyone on this call of being racist and xenophobic and sexist, et cetera. I think that we all agree on that. I think the important thing is to the same degree or to a similar degree that we've professionalized the community health workforce, professionalize these jobs too. Make sure that there are connections to the broader care system. I mean, often we've talked about the isolation. That isolation in the field means that critical knowledge about the care of an individual is not making it to the broader care system, right? And they're not sort of involved in conversations with doctors. They might not be getting the education about caring for someone with dementia or diabetes or heart disease that they need. So going back to what you were saying about training, Robyn, I think that's an essential element, not just of improving the job and the care, but professionalizing this workforce. And I think that's, it's just a missed opportunity, I think, thinking system-wide.
One of our best geriatricians here at Rush said to me once, he will know that the system is working when he knows what the direct care worker is thinking and that she knows what he's thinking about the person they're both caring for, and together coming up with a care plan. And, that was 15 years ago, he said that to me, and I don't think we're there quite yet, but any thoughts about what I said, Teresa, in terms of the CHWs, that provocative?
Yeah, no, it is, and you're right. But I like to think that we're starting to make steps in that direction. One of the things I'm really excited about is, the Department on Aging started some time ago, the critical events reporting system. And so we were able to train our caregivers and kind of bring them in. These frontline workers that are really the first level of care in the healthcare continuum. I really believe they are. Now, these individuals may not have the educational background that the community health worker does, but I tell you, given the right training, which they are afforded in this state, they are able to identify these red flags, which countless times lead to nursing home diversion or emergency room avoidance, because they are able to identify a cognitive decline or issue, a physical issue, and report it to the agency they're working for, the family, the first the emergency person, who's then able to get a medical appointment with a primary care physician and avoid an ER visit,
Absolutely.
a possible hospitalization, which could lead to, my goodness, it just snowballs. We've seen it. An emergency room visit leads to a hospitalization, leads to a rehab center, leads to nursing home placement, leads to never coming home.
They are the eyes, the ears, and the heart. Absolutely. Okay, thank you. Anything else about? So I also just want to wonder with you about the career ladder discussion. I think that, everybody's going to that as the answer. And I'm just wondering, I think people should be able to be direct care workers and continue as direct care workers too. The ladder doesn't have to apply for everyone, but I'm just wondering if you've seen some ladder examples that are better than others that you'd want to share with the group as we think about this workforce.
I think one really promising example, Robyn, comes from Tennessee, where the state has developed it's called the Quilts program. And this is a way that they've designed a really flexible and nimble training system where workers can take additional optional trainings and earn badges in various competencies. And with each step, the state is using their American Rescue Plan Act funding to fund a wage increase, right? So incremental wage increases over time. So just to reiterate that point, Robyn, I think that too often we think of the career pathway as direct care worker to LPN to nursing. Right. So many direct care workers don't want to become nurses. It's a different career altogether. But at the same time, as I already said, in so many cases, these are dead-end jobs, right? So, I think that absolutely we need to be thinking about adding more rungs on the ladder. And maybe that actually does bring that person closer to a career in nursing, if that's what they want to do.
If that's what they want to do, great point. But if not, they can elevate within the direct care worker career. Teresa or Paula, Director, any thoughts about that?
No, I agree. Just recently we honored a home care aide who's worked for our organization for 35 years as a home care aide. The number of people's lives she's touched, the number of people she's worked with, families and clients, it's just unbelievable. And boy, it's so heartwarming to hear her story. but we ask her why, and we said, did you ever, and with our organization too, the whole time, her tenure's been with us, and she said, I just love the work. Once I didn't plan on staying this long, but once I started, I knew this was the right fit for me. And so you're right, not everyone is going to have the desire. But when we talk about a career ladder, I don't know that it even has to mean moving into a as Stephen pointed out, an LPN, an RN, or some other field. I think it can just be building in a structure that allows for some goal setting and for some milestone achievement, and then some recognition when you do.
Do you feel like we're listening to that 35 year employee and or others in the direct care workforce to hear their voice about what matters and addressing the recruitment retention questions?
Yeah, I think that's a great point. I think that's really important for providers to do. It's not always easy, because a lot of times it's really hard to hear what you're not doing right. But I think if you really want to know, and only if you're going to take action on what you hear, I think you should survey your home care staff, your scheduling staff. As Stephen mentioned, I believe it's the hardest job in the agency, but survey those staff and find out about their challenges, what's working, what's not, how they individually like to be recognized, because not everybody wants to be recognized in the same way or manner. And so I do think it's critical. I mean, there's a reason she stayed 35 years, but boy, the amount of knowledge that she has, and she's been through a lot of changes over the years, and has a lot of insight. So we would be crazy not to listen.
Well, maybe our work in health and medicine will allow us to interview her. That would be wonderful. And more like her. We always think we have the answers, but we don't in this case, or any case. People who are going through it have the answers. So that would be great. So I have want to end with a question from the group. What other models and services are needed to help people stay in their homes? Expansion of telehealth. What do you think? PACE. I mean, what do you think the answer might be? Is there anything missing? I know, Director, you talked about the range of services and how creative you've been. Is there anything else? Personally, I think it's better connected with some of the managed care programs out there and making sure the aging network that they're mandated to work with us. That's my fantasy wish. I think that would make a difference. What are other people's fantasy wish?
Yeah, I really love the idea of, that I think it's integration into the broader care team, like real integration. That could be an advanced role, and it could also involve technology. So I just want to share one example. At PHI, we worked with a managed care plan and a few home care agencies in the New York City region to introduce what sounds like the critical incident reporting system that Teresa described, which sounds really wonderful. But essentially, these workers were in the field and using tablets to report on changes in conditions among the people they were supporting. And that information was being shared directly with a registered nurse employed by the managed care organization to help coordinate a response, right? Because in so many cases, it was lack of grab bars, lack of assistive technology in the home that was causing problems, and managed care organizations can intervene and save money, right, in preventing the hospitalization. But that intervention also involved a Care Connections senior aid role, where these workers were, supporting workers when they were experiencing challenges in the home. That senior aid role was a member of the care team at the managed care organization. So I think, models like that, where we can use technology to connect a worker directly with someone at a managed care organization, for example, who can really take action, and then also have this opportunity for advancement for experienced aides to participate in care planning and work with aides in the field to sort of implement care planning, for example, following a discharge. I think that's my hope too, that greater integration and greater respect for their role.
I would add that it's really important. I think often as social service providers, where we really hurt ourselves is we don't always operate, particularly in the not-for-profit world, as a business, using the right business models. And I think we all know that funding is limited, and it's one of our greatest challenges. And so I think trying to get very creative, because we know that, and look at outside partnerships and agencies that can help enhance the participants' lives. One of the things we've done at our organization that I'm really extremely proud of, as we've turned to some larger for-profit entities, nationwide groups like Ameren, Illinois, who are really always looking to community-based organizations to fulfill part of their mission as an energy provider. And we've been able to install smart lighting and LED lighting,
Wow.
which sounds like a really small thing to do in individuals' homes at no cost. And so you go into a senior's home and you put some new lighting in the bathroom, and for Ameren, maybe it's about the dollars or the kilowatts saved. But I tell you what, for a senior, something as small as some $6 light bulbs can give them a real sense of pride in themselves and what they're able to do. We had a client, I don't want to take too much time, but we had a client who had regressed and was not interacting with their home care aide very much and wasn't doing their self-care. And we were trying to really trying to figure out what was happening. And in conversation with the daughter, she shared that he was really having some problems due to low lighting and not able to groom himself. He wasn't able to shave his face anymore, and he did not want the home care aide to shave him. That was just, for him, that felt like he had lost, all of his sense of individuality and so on. And so without him, knowing that we ask about coming in and installing some new LED lighting, and the next day he wanted to go out with the home care aide to go to the grocery store, to run his errands, to get his groceries. He was interacting. It was like he was a whole new person. He was himself again. And so I think, there are lots of stories like that, but I think seeking out and leveraging out other partnerships and collaborations is going to also be really critical, because again, with those dollars limited, we have to look at other entities who are able to provide those resources that are going to help not just make our job easier, but to make that customer experience on the other end so much more.
That's wonderful examples. So I'm aware of our time, and I'm just wondering if there's any last words that you feel need to be said. You have been the most unbelievable panel. You've made it so easy for me as a facilitator. And just any last thoughts, or do you feel like we're good to go?
I would just like to say that all the advocates that are on this call, that it's up to all of us to start talking more and more about how important this work for direct care workforce is. And personally, I love, again, Teresa, you talked about the woman who 35 years, I had the honor of meeting her at that luncheon, giving the awards. And let's do a video of her. I mean, we do a marketing piece about why she does what she does. Because we have to be the ones who make it attractive as well, and say why this work is so important to us, and how we truly, all of us, some of us been around a longer time than others, but why we do what we do and why we love it so. And that the aging population for us, and as we age, I always say now, I work for myself. I basically, we have to talk about the benefits of the joys, the struggles, but also the incredible honor it is to work in this field. We as advocates have to be strong in how we encourage people to get into working in the aging field. It's up to us.
Thank you for leaving us with activation, Director. I mean, we need that. We need to keep, we've talked about recognition, value, all of that today. You're seeing in the chat how motivating this has been for the audience. Thank you, audience. Great questions. Thank you, Health and Medicine Policy Research Group, but particularly our panelists for giving it your all today. Everybody have a good day. Take care. We'll be sending the recording out in a few days so everyone can listen or send it on to anyone else who missed it. So be well. Thank you all.